Okay, hopefully this works. I'm gonna get a microphone over here, so hopefully there's not too much background noise. Um, so I'm just gonna start off. We talked about bone loss descriptions. And we talked about the extent being either localized or generalized, depending on if it's less than 30% of the mouth or more than 30% of the mouth. Then we talked about severity. There's stage 1, stage 2, stage 3, and stage 4. You'll learn more about this because there's also grading that goes along, grades A, B, and C that go along with the stages. But for our purposes, we just look at the stages, which is pretty much kind of indicating the amount of bone loss or attachment loss. And then there's the complexity, which talks about the pattern. So we can have horizontal bone loss, you can have vertical bone loss, we can have furcation involvement, meaning the bone level it has gone down into the furcation. And then we can have moderate to severe ridge defects, meaning the actual kind of shape of the arch can get thinned out and you can lose bone in the actual shape of the arch. And that can also be localized too. So some demonstrations here, we talked about the looking at horizontal bone loss as more straight across from side to side. We have to consider where the CEJ is, where right at the kind of the neck of the tooth. If it's higher on one side than the other, the bone level may also be slightly angled, but that still is horizontal. But basically, in general, horizontal is when you just lose bone straight down, like an elevator just dropping down. And vertical bone loss is where you still keep some height, but it thins out. You can see here it's still keeping height, but it's thinning out and it's coming more at an angle. And sometimes it's very apparent from between one tooth to the other like this. You can see it's thinned out more on this side of the premolar than this side of the premolar. So that's complexity. That's just showing that. Okay, so here we have, we're looking at some horizontal bone loss patterns. So the alveolar crest should stay somewhere between 1 millimeter to less than 2 millimeters below the CEJ is considered normal. So that's very close really to the CEJ. So it's hard to determine it specifically. You can measure, and I would encourage you to, when you're in a radiology lab, when we can ask Teresa or myself to take out the little measuring device, because you can actually measure when you're taking films, and you can kind of say, okay, 1.5 millimeters, from here to here, and you can actually measure it, and it's calibrated, and then that can give you an idea of how close the bone should actually be. Now, the bone is never going to be right up to it. Typically, it's called a biologic width, and it's just where the bone lays naturally, happily below the CEJ. So then we have the loss of the lamina dura. Usually you start to lose that. You can see it's not as defined in some of these areas, and it's certainly not defined at the crest. So we've lost the lamina dura. And then it's hard to determine whether disease is active or stable from the radiograph, because this is just a moment in time. So you really have to compare radiographs one to the other in order to see, if something's changing. Vertical bone loss, it's a greater degree of bone loss on the interproximal aspect of one tooth compared to the neighbor tooth. So here's a really good example. You have bone loss over here, the CEJ is up here, you have bone loss here, but then it goes vertically downward. Now, sometimes this can be exaggerated if the tooth is tilted, that can exaggerate the vertical bone loss, but in general, even if it's tilted, it's still, the bone loss is vertical. And here, this is a dark film, but you can see it's very vertically a deeper vertical angle between those teeth. May require surgical treatment to try to regenerate the bone. So like I was saying before, periodontists don't have any kind of structure really to build bone up. You need kind of almost a scaffolding, and there's nothing but root. And usually the root is diseased, and then you root plane it, and it just changes the whole habitat. Whereas if there's this vertical, they have this whole structure here of the slanted bone to help build up, to help build bone into this slanted, and they can usually get a little bit of a regeneration if it's a vertical defect. So here's an example of localized versus generalized. You can see how the bone level is relatively healthy all through here. And then in this one area, we have some bone loss, as opposed to just having bone loss all throughout. So stage 1 used to be just called slight, and now we call it stage 1, and the bone level cannot go past 15%. So it's the coronal third of the root. So it's the part of the root that's closest to the crown of the tooth, and it can't be less than 15%. If you're taking this whole system into consideration, it's less than 15%. So it's really not much to be staying within the stage 1. Stage 2 is considered, used to be called moderate, and that's 15 to 33%. So it's a little bit more. So, but still, it's only a total of no more than roughly a third of the whole root system. So it's still, it's still fairly, I don't want to say the word mild, but, there's still a lot of bone around the roots, even though this is getting to be, it's certainly more than slight or mild. And then stages 3 and 4, you really have a hard time determining between 3 and 4 from just looking at radiographs. You really need to see the bleeding, you need to see the Perio chart, you need to see the furcation involvement. So there's many other things that you need to see besides just a radiograph. So that's why a lot of times we just say 3, 4. It's kind of hard to tell unless you can see that the bone is just absolutely dropped down close to the apex. Then you're like, well, that's clearly a 4. But sometimes it's harder to determine between the two. But this is bone loss extending beyond the middle third of the tooth. So we have our middle third in here, and it's extending beyond that. So you can see there's definite furcation involvement. And we're almost getting down to roughly 50% bone loss. So in a healthy person, there's a well-defined, this is just to kind of recap, in a healthy person, there's a well-defined alveolar crest, and the bone level is with less than 2 millimeters from the CEJ. In slight, we're going to start to see a little bit of the widening of the PDL, a little bit of maybe a moth-eaten appearance, or a little bit loss of the lamina dura, and it's going to start to kind of round off in the posterior as opposed to being kind of square. And then we also start to see it's eroded or kind of a moth-eaten appearance, and we're going to be farther than 2 millimeters away from the CEJ, but less than 15%. Stage 2, we're going to be somewhere between 15 to 33%, and clinical attachment loss, or we call it CAL, that's going to be when you calculate, you're calculating the amount of recession. So you measure from the CEJ, you measure from, hold on, I was trying to pull something up. Just a second. Why isn't that coming up? You measure from the CEJ. Sorry, I'm doing something on my computer here. To the bottom of the pocket. And so you can either do it that way, or some people simply add recession to the periodontal pocket. Because if you measure your periodontal pocket, let's say you measure your periodontal pocket and it's a 3. So that's actually, a healthy pocket, really, but let's say they have 2 millimeters of recession. So their clinical attachment loss is actually 5. That means that all that space from the CEJ to the bottom of the pocket, nothing's attached to it. So that's the clinical attachment loss. So if somebody has 3 to 4 millimeters of clinical attachment loss, that means that in general, that tends to be the same, that falls into the same category as 15 to 33% of bone loss. So you would see if somebody has no more than a third of the bone loss, their clinical attachment loss shouldn't be really more than 4 millimeters total. So that's a pretty small amount of bone loss because people can have a 3 millimeter pocket and it's normal. So that's really just 1 millimeter beyond that, really. So stage 2 is still fairly mild. I'm still trying to get my PowerPoint is not functioning. Hopefully it's recording the right one, but it's okay. I think now I got it finally. Okay, and then stage 3 to 4 periodontitis is going to be more severe or advanced. You're going to have more bone loss. You could have vertical defects. It's going to be extending to the middle third of the root and beyond. And you're going to have 5 millimeters or more of clinical attachment loss. And then stage 4 is this could be say 3, this could stay 4. Then you're just going to have further, you're going to be even further into the bone loss and other things involved, like more mobility and furcation involvement and that sort of thing. And you guys are going to learn a lot more about the staging and there's more details to it, but for radiographic interpretation, we don't have to go into all that detail yet. So here's a couple examples of some significant bone loss. I mean, this is coming right down to just the apices there. And you see just a ton of debris in between these areas. Like, here's obviously where the bone loss has stopped, but then all this stuff in between, what does that look like? Well, in real life, this is what it looks like. Heavy, 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 heavy lingual calculus, calculus on the facial as well. And then and then below the gum line, all that bone is eroded away from the disease. So that's one example of what it can actually look like. It can look like different things on different people, but you can see how much calculus is on the teeth as opposed to what you can see on the radiograph. Like, that's a lot of calculus, but then when you see it in real life, it's like, holy moly, that's a lot. So when we think about interpreting for the complexity and we think about the furcation involvement, we have to understand that furcation involvement doesn't always show up when it's very, very mild. Like if it's just starting to involve the furcation, we don't always see it, but we can feel it with the probe. And that's why it's so important that we're probing. But when you're losing that bone in between the roots, this not only brings them to a whole nother level of complexity, because now they, the patient, and you, the clinician, have to figure out how to keep this area clean. So now you have this little tunnel nook-like area that's harboring bacteria, building up calculus, and very oftentimes it's covered with gum tissue, or at least partially covered with gum tissue. And how do you clean that? It adds complexity to the patient's case. So we have things that, tools, and we learn how to clean around them, but the patient struggles to keep these areas clean on a regular basis. A widening of the PDL, you can see how this PDL is widened in a lot of these areas here. That usually also signifies complexity and potentially mobility. There might be more movement in a teeth. So here we have an example of advanced furcation involvement, and then you can start to see a shadowing. This is like just beginning of some furcation involvement. And then we can see some cervical caries right here, how it's dark right below the CEJ, pretty defined margins. So there's some cavity forming there. Here we have horizontal bone loss. It's pretty much straight across in most all these areas. This is all horizontal bone loss. This might look a little vertical, but sometimes there's still some bone back there. You can kind of see a little fuzzy, and then some stage 3 furcation involvement. So here again, showing just the long angle of the teeth. The CEJ is slightly off, but the bone level is still dropping fairly horizontally. Here, there's a little bit of it's the bone's leaving a little bit more on like the lingual aspect than the buccal, but in general, this is still classified as horizontal. Stage 3/4, probably more of like a 3. This almost to me looks closer to a 4. But again, like I said, you can't really tell until you get your Perio chart and all the pieces. So here we have horizontal bone loss. You can see some of this, see how this is a little angled, but see how the CEJ is angled. So that kind of makes up for that. The same here, our CEJs are angled and this bone is a little angled, but in general, we still call that horizontal because it's pretty much dropping down fairly parallel, and especially when you consider it parallel to the CEJ. This is all, and this might look a little bit sloped, but look at where the CEJ is. This tooth has tilted. So this is one that I was saying you have to kind of be careful when a tooth is tilted, because look, the bone is pretty much at the CEJ of this tilted tooth, but this tooth has some horizontal bone loss. Here we have some more horizontal bone loss, stage 3/4, because we're well below the middle third of the tooth there. So this is all stage 3/4 horizontal bone loss. Here we have an example of what can be considered overall generally healthy. We can see a lamina dura. It's pretty much blunted. You can see there's a little widening of the PDL perhaps right here. So somebody could, if somebody, and then it gets kind of dark, so it's hard to see right here and here. Somebody who really wanted to argue that this is stage 1, could argue it. But for our class, we have to draw a line somewhere. And so we're going to look at the CEJ, and we're going to look at the fact that we see some lamina dura, and we're here, and here, and we're going to say, we're going to call this person healthy. Now, the one thing that you'll find about periodontal disease and diagnosing periodontal disease is it is a spectrum where everybody has a different opinion. It's very hard to draw a definitive hard line in the sand. Everybody kind of interprets things. Doctors, hygienists, people all can say, well, I think this or I think that. So we have to be aware that when we make our diagnosis, especially when our instructor says, what's their AAP, what stage and grading do you give this patient, you give your rationale. And that's what really matters is, and the instructor might disagree with you. And of course they have years of experience, so they will probably help shed some light on it. But it's important that you listen to them, but then take it all into account, because when you go out into practice, you'll notice that some doctors are more conservative, some are, just more, I don't know if liberal is the right word, but conservative, meaning they treat early, they treat hard, they treat fast, they don't want it to get out of hand, where other dentists might be like, oh, we can sit and watch this. And this is just the difference between practitioners. And, so there is a little bit, we always say periodontal disease is, everybody can interpret things ever so slightly. But for this, and for our purposes of diagnosing with the limited tools, we don't have a perio chart, we just have these radiographs. We'd look at this and call it healthy. So here again, we have in general healthy alveolar crest. It's pretty squared off. In the posterior regions, we can see the lamina dura. This is probably, I wonder if that's the mental foramen. That's likely the mental foramen. You can see the submandibular fossa. I'm just pointing out other things I see. We know this is an amalgam filling. Here's a blurry x-ray. And this is going to be a generalized, probably stage 3, because what we tend to do, some of these might be a stage 2, but we tend to pick the worst areas and we stage it to whatever's the worst. So if we have an area like from here to, oopsies, go back. So if we have an area from here to here, which is definitely more than a stage 2, but maybe this is, we might argue that that's stage 2, but if this is stage 3, then we call it a stage 3. The patient falls into a stage 3. Horizontal bone loss. Here we have healthy alveolar. There is some widening a little bit, but that could be normal for that patient, or it could be from clenching or grinding. But in general, we can still see the lamina dura. It's fairly close to the CEJ. It's kind of knife-like or sharp. So this is kind of a pointed alveolar crest. So that's healthy. Here we have this one, it gets a little dark, so it's hard to see these anterior ones. But again, here we can see a thick lamina dura throughout here. We can see it's pretty blunted. The PDL is nice and snug. So we would describe this patient as healthy. Here we have some vertical bone loss here and here, furcation involvement. So this patient's in a 3 at least. So this would be vertical bone loss and stage 3. And then we, again, just reminding you the difference of taking an image that is parallel as opposed to an image that is bisecting. It's very important when we're dealing with our perio patients that we get pictures where we've taken nice paralleling technique. And of course, your vertical bite wings or your regular bite wings, depending on where their bone level is, will usually give you that good image, but we also try and get it as best you can with your PAs. And then here's that picture from the beginning. This is obviously like a stage 4. We see this is likely like what we'd call a through and through furcation, depending on where the tissue is. But we can obviously stick our probe probably from one end right through to the other side of the mouth in this furcation. So this patient, heavy calculus. So this patient's probably a 4. And then here we have this is a good example of more like a moderate or a stage 2. We lost some of the lamina dura. We can see the bone level. Here's the CEJ, the bone level's here. So it's about half again, as far as where we'd want the bone level to be away from the CEJ. So this is a good example, especially in this area. You can see it the best that this would be a stage 2. And that's it. All right.